So I'm not going to take a lot of time to introduce Julie because she told me not to take a lot of time in introducing her. And I could go on and on about her. So I'm just going to say a few things. So she's a very prominent clinician researcher in stroke recovery, senior principal research fellow at the Florey Institute of Neuroscience and Mental Health in Melbourne, Australia. And she's the director of their new Center of Research Excellence in Stroke Rehabilitation and Recovery. Somewhat kind of similar to the CPSR in some ways. So before I kind of finish my introduction with Julie, I'll just say that having her here is a wonderful opportunity for all of us. And when it comes to stroke recovery and rehabilitation, Julie is a true rock star, so you're in for a real treat today.
Oh,
and
thanks.
She's going to be talking to us about her very already famous AVERT trial. So,
Thank you. Julie. Thanks very much, Dale. It's lovely to be here. It's always lovely to come and visit people that you've been spending time with. Really today, I thought the narrative for this presentation could be around the journey. I hate using that word because it's been so popularised in sort of cooking shows and other shows, but the journey that I've been on looking at the area of early intervention. And here I'm going to talk about early mobilisation, which is the sort of common term that has been coined for when should we start the physical rehabilitation for people after stroke. And it's very useful for me to put in context where did this sort of all start from. And so in 1991 there was a first randomised controlled trial of stroke unit care that was conducted in Norway, and in that trial where they were comparing a stroke unit to a non-stroke unit and showing superior outcomes for stroke patients managed in a stroke unit, they mention early mobilisation within 24 hours of stroke onset. And it was starting to look at this when I first came into the scene that sort of kicked off my interest in the area. But that was 91. Then in 2001, the stroke unit trialist collaboration of the Cochrane collaboration, led by Peter Langhorne, did a review again looking at stroke units, important, best level, highest level care that we can give to our patients. And again, they talked about early mobilisation. And then the first pilot RCT begins, which is comparing actually the intervention within a stroke unit. So the other evidence had been a stroke unit that encompassed this care to a non-stroke unit environment, and we started the first randomised trial in 2004 that's comparing the intervention delivered in the same space in a stroke unit. It first gets mentioned in clinical guidelines, as far as I can tell, in about 2007. The first pilot randomised controlled trial was published in 2008. We completed our Cochrane review after that in 2009. And then in 2015, we completed an early adoption review, which I'll get to prior to the phase 3 results being published. So that's sort of the time course of activity, and I'll delve into this a bit more deeply because there's been a lot of people or other people working in this area. But one of the major challenges that we've always had, and we still have in rehab and recovery, is definition. And so when I first started looking at this area and I asked what was early or looked at what people were calling early, you can see the range of definitions that people were using for early. So anything after stabilisation, when people could cope with 30 minutes of training, quite diverse. We just didn't define early well. And then in terms of what mobilisation was, and this is still problematic, it could be moving people's limbs while in bed. Of course, for you guys, it also is mobilisation of cells, right? So the terminology gets used in varying ways. It moved from in bed all the way up to exercise and physical activity. And so there's this very significant problem of making sure that we understand what people are talking about when they talk about it. But for me, the question was always, both, is it the time, the first time, so when we start it, or is it also what we're doing that is important in looking at recovery? And that was always my sort of starting point in looking at this. So I started here in 2001 as a new postdoc. And I will just say here that although the AVERT trial has taken a lot of my life up in the last 15 years, it's by no means the only thing that I like to research, but I'm just going to focus on it today. So 2001, I came in, read the stroke unit trialist review and read the early randomised controlled trial that was conducted in Norway and went, this is interesting. I'm a rehab person and most of my rehab has started at when I first started, day 17 was average for people to be transferred to rehab. Now it's about day 5, day 7. So what if we could move rehab earlier? What if we could shift it into an earlier time frame when it seems that there are things going on in the brain that would be conducive to getting more recovery, a better trajectory? And that's really what started the question. So just to look back on, what did we know in that time in 2002 when I started to really delve into this? And I thought I'd show you some of the trials evidence, some of the clinical opinion and some of the preclinical work that I knew of at that time that I explored to sort of set the scene for why you would do this research and what would you do. Well, I'll start with the preclinical work. Now, this is an article which I don't expect you to read from New Scientist Archive, and it is from Tim Shallett's group in the Journal of Neuroscience. And the bits that are important are that in this reportage it says too much exercise too soon after brain injury could make the damage worse. The size of the injury doubled. It's a very dramatic effect. And then down here, it's unclear whether human victims of stroke, like brain-injured rats, could make their problem worse by exercising too vigorously too soon. But what is important at the clinical level is that we as clinicians knew about this work. So it had delved down, it had filtered down into the clinical world, and there was concern. So when I started talking about doing earlier intervention, people said, but what about the animal studies, which are suggesting that it's not a good thing? And so I took this work and the other studies that were coming out at that time to our basic scientists and asked them to do journal club and said, because I didn't know how to read those papers then, and said, can you tell me what you think of this and should I stop now? And they said, no, you shouldn't stop now. There are flaws in this study. It's not absolutely definitive. I think I wouldn't stop based on this work. Okay, so that meant great, I can keep going. So then I looked at what was in the literature at the trials level. Within 2 days of stroke onset, there was nothing in that space. So no studies that had looked at adding an intervention that was rehabilitation focused in that early onset after stroke. But there was also a smatterings of work, and you can see they're not big studies and they weren't well defined. You couldn't work out exactly when they started, and of course the interventions were all highly variable. So again, I looked at that and thought, okay, there's not much there. And if we look at opinion, there'd been a study that was published in 2007 but done much earlier that just looked at health professionals in Scotland and asked them their views about early intervention and mobilisation, and there were very mixed views about who should do it and when should it begin. So that was our state. And then in terms of clinical practice guidelines, there were no clear guidelines. And you can see here, it's after medical stability, as soon as possible, as early as possible. So nothing that was really going to help fix us in terms of what we should be doing. Indirect evidence. So to me it seemed that this was a great target for spending some time doing research in the area of very early rehabilitation. And I spoke to my director and I said, this is what I think I want to do. I think I want to do a series of studies that get me to a point where we might get some evidence that we can use to guide practice. And he said, look, that's probably going to take you 10 years. And I went, yeah, sure, no worries. 15 years, but never mind. And these are the reasons. You know, the huge burden of disease. We've had a lot of dialogue around early rehab. It should start earlier. It helps recovery. We think there's some indirect evidence of benefit. And also, we really had uncertainty about the timing. And certainly uncertainty about harms and safety. So we don't know. And of course, if you were going to do it, there were going to be significant barriers to actually implementing something like this, given our current care models. So all of these were, to me, an indicator of why we should have an exciting research opportunity. So I've spent time trying to develop up this study over a sort of normal phasing process that you would see, where we looked at the modelling of it, observing what was going on in different hospitals, mapping behaviour, looking at what's happening in Norway as well, in that site where they had the early intervention program. I went there and spent a lot of time mapping data in their site so that I could try and describe it. And in fact, when I gave them the data, they said, "Oh, is that what it looks like?" Because they'd been doing it so long, they couldn't tell me what it looked like. I had to actually go and try and understand what they were doing. And then we ran the exploratory phase 2 trial from 2004 to 2006. And as you know, or you don't know, but we ran the big trial from 2006 to 2015, so a long time. And when we were doing the phase 2 study, we looked at, it was multi-centre, so 2 sites, but very small, 71 patients. And we were really interested in safety and feasibility. It was a true phase 2 trial. But we also looked at mood, quality of life, ADL, timing to walk unassisted, and also health economics. But in all of those areas, the safety looked okay. It was feasible. The mood data looked quite promising. We had fewer people experiencing depression at 7 days with an early onset intervention. Quality of life, there are not really much in there. Time to walking unassisted looked really promising as well. And the health economics also looked good. We also looked at what happens when you combine a couple of data sets from 2 different trials that we had aligned, which was the AVERT and the Veritas trials in the UK. The main thing I'll try and get you to see is that if you're looking at independence at 3 months here, that in fact you were 3 times more likely to be independent if you had the intervention based on these pooled results. So that also looked good. At the same time, we also had coming out this study, or it came out in 2012, but we were aware of this study from much earlier, evidence from another trial suggesting that you had a increased dependence, 2-fold increase in dependence at 3 months if you started early. So again, we're in this space where there was nothing coming out that was definitive. So we still needed to do the big trial. So we've moved on, and here there are now 3 studies, and you can see the size. It's only 155 people in them, but they're there now in the space, and no clear evidence, and you keep going at that point. So this is when we started the big trial, and that was after we'd finished from 2004 to 2006. We finished the phase 2 trial and then quickly rolled over into the next study, into the big study, and that was because of the fact that we got funding then as well. So you had to hit the ground running. And the AVERT trial, which stands for a very early rehab trial, was always intended to be a real-world pragmatic trial, meaning that we wanted to conduct it in hospitals, with the staff in the hospitals delivering the treatment, not having external people coming in and delivering the treatment. It had to work within the real world. And it ended up being an international trial with parallel groups being randomised within 24 hours of stroke onset into either a very early and intensive training program versus usual care as the comparison. And we had clinical hypotheses based on those phase 2 results that it would improve functional outcome, and we've used the modified Rankin scale. 0 to 2 means little to no disability for those who are unfamiliar. It's considered to be a really important standard outcome measure in acute trials. It's quite a blunt instrument, but is proven to be a very good outcome measure for large stroke trials, and we wanted to do the same. We also thought that there would be an impact on immobility-related complications, because if you're starting to get people out of bed, walking upright early, then that should have some impact on our complication rates. And also that people would walk, regain their ability to walk early. So I'm going to take you through a few of the outcomes of that trial, which have been reported now in the Lancet. We published that last year. And just to take you through some of the key findings, not everything, and then to talk about the next sort of iteration or the delving down into the data that we pre-specified, because it's still early days, even though we finished follow-up in December of 2015. So this is what the trial looked like on paper. So we had a sample size of 2,104. And people would have their stroke and come into hospital. They had to be recruited within 24 hours of stroke onset. So we had to screen them, get them in, and then they were stratified by stroke severity and by site, and then were randomly allocated into their first intervention starting within that 24-hour period, and then continuing daily throughout the course of their stay or until 14 days, whichever happened first. And then the usual care went into the usual care group. We had the primary outcome set at 3 months and a 12-month follow-up. And I've just wrote down here that one of the things that we try to do, because it's single blind when you do rehab trials, you can't blind the therapists to what they're doing unless you're giving a device, and there's a placebo device. But in these kinds of activity-based trials, you cannot blind the intervention deliverer. And so, but one of the things we had to do was try and maintain our single blind of our outcome measures, our outcome assessors. And so we did that by consenting patients to a trial that was comparing 2 different types of rehab, and we didn't tell them anything else. And all of the ethics committees agreed to let us do that, so that the patients didn't know what they were actually signing up for, except that it was something to do with rehab. So the principle that we had was that, or the average, we obviously have a detailed protocol sitting behind this, but it was adding 3 additional out-of-bed sessions of activity. And I'll talk more about that a little bit later in the intervention group. And that was on top of usual care. And then our primary endpoint was the favourable outcome on modified Rankin scale, and then some safety outcomes, of course, related to death, serious adverse events, and breaking those down into neurological and immobility related serious adverse events. So that's sort of the first tranche of data. So we ran till October 2014 was when we shut the trial down. We aimed for 2,104 patients, and I'm a finisher, so we had 2,104 patients. We kept going until we had them. We ended up with 56 sites, and I would not have told you that that would happen at the beginning. I've learned a lot about clinical trials doing this trial. And we were in 5 countries, which included Malaysia and Singapore. And if you're in the UK and you believe that Wales is a separate country and Scotland is from England, then we were in 8 countries. So we had, this just shows you the size of your screening that's necessary. We screened 25,000 patients for the 2,000 that were enrolled into the trial. And that, a lot of them, you can see here, they either had pre-morbid disability, so they were outside of our exclusions, or they were in our exclusions. We also can't co-recruit, so there are over 1,000 that were recruited into another study, usually acute thrombolytic trials or endovascular studies that we couldn't get into. People who were too unwell based on our inclusion criteria, And I haven't put them all in here, but our inclusion criteria were very broad. You could have a previous stroke, you could be over 80, you could have been treated with thrombolysis. The only exclusions really were people who had a disease that was likely to progress, or who'd gone to ICU, or who were very seriously unwell in that first 24 hours, or who met our physiological parameters, which were related to set targets for heart rate and blood pressure, etc. And then we had other problems. Because this was pragmatic, we didn't have a recruiter. We had no nurse running around recruiting patients. The staff were the ones who were doing that for us. So if they went on call on the weekends, then we couldn't recruit. So we lost people for that reason as well. But we only had a small number who refused. And that was, I think, testament to the fact that people are interested in being involved in rehab studies. So we had these, this is how the randomisation went. You can see that we had some people who weren't stroke, but in intention to treat world, all of those patients were included in our primary outcome analysis. We had very few people who refused to be followed up or who were dropped out of the trial. And that meant that we got a remarkable follow-up rate of 99% of patients at 3 months. And I can tell you with the 12-month data that we've only lost to follow-up 2.5%. So we've got incredibly good data. And that is a testament to the blinded assessors and the people who are involved in the study who were so passionate about doing this trial. They really wanted to do a great job, and they did. So the main things to look at in terms of the demographic is that they were really well balanced across the groups, as you'd expect in a study of this size, that 26% of our patients were over the age of 80. And that's uncommon in a lot of acute trials. There's cut-offs of around 75 in many acute studies. They were randomised on average at about 18 hours after stroke onset. 45% of the patients had moderate to severe stroke, which is good. That's what we were hoping for. And 12% had intracerebral hemorrhage. So we didn't exclude those patients. And as I said, people were eligible with TPA, and about a quarter of our patients had been treated with thrombolysis prior to coming into the study. In terms of looking at the intervention, the main thing to take from this slide is that we achieved significant intervention differences, and that was a key focus. Something that is often lacking in rehab studies is that you don't describe what your intervention was, and to us that was absolutely essential, that we had to be able to describe what was delivered, both in usual care and in the intervention group. And we put a lot of effort into working out how to do that, to try and make sure that people would deliver the intervention. And you can see that there were significant differences across both groups in usual care and early, the VEM, the very early mobilisation. The main thing here is that in this group, they did start pretty much straight after they were randomised, so around 18 hours as the median. But in the trial, the usual care group started within 22 hours of stroke onset. So not stroke admission to hospital, but stroke onset. And that meant that 75% of all the patients in this trial started out of bed activity within 24 hours of stroke onset. So that's a large number. Now, you heard me mention before that we had a focus on frequency, and we absolutely did. So the 3 times per day, added on average 3 times a day, was very varied according to how you presented in to the acute hospital. So if you were, and we had 4 levels of intervention, and I'll talk a little bit about that. But if you were able to walk, then you had a much higher target for frequency per day and amount per day. So these are the averages. So they seem quite low, but there's a lot of distribution around these averages. But you can see we got our 3 extra sessions per day, and also that the daily amount per person, which only included physical therapy data, was higher. The total amount over the life that people were in the trial, as you can see, then becomes quite a bit higher in the group who had the early intervention. So the reason we didn't have minutes per day for the nursing intervention, so it's a nurse, physical therapist, physiotherapist, I'm allowed to say here, working together intervention, is that nurses don't typically record minutes of time spent with patients. And in our phase 2 pilot, we had asked them whether they could do this, and they said it's so out of practice for us. It's not how we normally do it. We can give you when we do it, we can give you what we do, we can give you how often we do it, but we can't give you the time. And we said, okay, well, let's just go with that, because we want good data. We don't want... And so that's what we did. Now, the usual care time changed over the life of the trial because it ran for so long, and partly that's because of this. We found a huge hurdle in people not coming into hospital quickly. A lot of people would not present into hospital. And if you think of Australia, which was our first starting point, geographically distributed, we had people in rural centres, we had people in metro centres, and in our metro centres there's choices of hospital. We had people with mild stroke who were waking up and going, oh, I don't know, have I had a stroke? We had people with severe stroke who might be left on the floor. We had a lot of people who didn't come in the window, and that's when we realised early that we had to expand the study into multiple sites because we were not going to make the patient recruitment, because that was a major barrier for us. But this is the point that I wanted to make, is that over time the time shifted. So about 28 minutes earlier each year of the life of the trial, people started to start their intervention earlier in usual care, and we could track that. So this was our result. The result was that we had a look at our modified Rankin scale. Remember, this is no to little disability. 46% of patients were in that group, but more in the usual care group. And that was an absolutely consistent finding. You can also see that there's a slightly higher rate here of death in the early group compared to the usual care group. So some people have said to me, well, that's only 4%. Do we really care about 4%? And I'm going, if you multiply the 4% by how many people have a stroke each year, would you want to be in that 4%? And the answer, of course, is no. So it might seem like a small amount, but it is significant and we can't ignore it. So we obviously pre-specified some subgroup analyses, and we looked at age and stroke severity and stroke type and thrombolysis, timing, and even looked at across the different regions that we did the study in, and everything is sitting on this side of the line, favouring usual care. Now, none of the interactions were significant, but we did find the hemorrhagic group sitting further out from the line, and also you can see the severe group are very widely distributed. But TPA, there was no real difference in whether you'd had TPA and then got up compared to whether you had TPA and didn't start early. So it didn't add any extra burden. They were just the same. Interestingly, and I haven't got the data here, but there's an interesting interaction in this adverse event data that suggests the 65 to 80-year-old group, and there's nearly 1,000 patients in here, have fewer serious adverse events that aren't fatal with VEM. But that's the only finding that we've got that's in favour of the intervention at the whole of group level. So we also we did a statistical analysis plan before the study was finished. Again, my goal's always been to try and do absolute best practice for studies design. So we did that at the beginning, and what we set out was what all of the questions were that we really wanted to answer and what the analysis plan would look like. And one of the things we definitely were planning to do was look at the pre-specified dose analysis. So in this analysis, we were interested in not whether people were whether they had complied with the intervention, but what effect did the dose have on their outcome. And so we grouped the patients together and ran the analyses in that manner. So just to remind you, with the intervention, it's not just when you begin, it's what you're doing. And that, as I said, from the beginning to me was so important that we get this right. So we actually had a package of care, and we knew that. And it's the time, so how soon after stroke, the frequency. So how many times a day were you trying to apply this out-of-bed intervention? And then the amount. So how many minutes were you doing the intervention for? And we put these into a regression model and also into a used cart analysis, and I'll take you through these quickly, just focusing again on the primary outcome, which is favourable outcome on the modified Rankin. We adjusted for their baseline stroke severity and age in all of the models. So now I'm going to tell you what it was and also what it wasn't. So with our intervention, it was a rehab-focused intervention. So not just getting someone up to sit in a chair. The sitting in the chair component actually was not counted in the intervention. So it's out of bed, sitting, active sitting, standing or walking, task-specific intervention that was guided by the protocol. And there were 4 levels of intervention according to how you presented at the time of your stroke, so your functional level, and we adjusted them up or down with recovery. Now that meant that if you came in at a level 1 and then you were doing well, then by day 3 you might have been a level 2 and your protocol would change. By day 5 you might have been a level 3 and your protocol would change. Or you came in at level 4 and then you got worse and you went down to level 3, level 2. I'm telling you this just to say that we're trying to look at this therapy data now, and you can see how complex that data set is. We have 85,000 therapy records and we have people changing their therapy. So it's quite challenging to look at this. So the treatment package was time, frequency and amount, and it was not sitting out of bed. So if you sat out of bed, that isn't counted in the minutes of treatment because it's not a treatment, it's a passive exercise, which might still be important, can I say, but we didn't measure it. We can, but we haven't. And we did the intervention monitoring and achieved these differences in each of these key criteria, so that was good. So this is the regression analysis, and what we saw, which is where we're interested in looking further into the future, and I bring this up because I really value your thoughts about it too, is that for those who had a more frequent but lower dose intervention, that is associated with a favourable outcome. So if I take you through this, where we look at, and the way to interpret this, so if I look at the frequency, which is the median daily sessions, that the odds of having a favourable outcome increased if you keeping time to first mobilisation and daily amount constant if you change the frequency. So if you increase the frequency, you have an improved outcome. Now, if you increase the amount, keeping the other factors constant, it reduces your chance of a good outcome. And time is actually still in favour of earlier, but not significant in this model. So this is a really interesting finding, and one that we are exploring further at the level of delving down into the data again. And there was a reason that I focused on adding frequency and not just on doing large doses of training. And that did come from a number of sources of literature, and particularly related to whether or not we can accumulate dose by doing interventions in smaller packages with rest in between, and also the concept that we actually need rest to be able to integrate our learning from session to session. And also at the pragmatic level, that if you're an acute stroke survivor, you are not going to be able to cope with large, long sessions of training, but you could cope quite well with smaller, frequent sessions throughout the day. So that was absolutely front and centre in my mind when I started the intervention. So just to quickly again sort of show you what a cart analysis looks like. It's a data-driven binary partitioning statistical method. It has sort of a way that you can put in all of the factors that you're interested in. And then the analysis itself runs and also has a test and a train, or a test and a retest component in how the analysis works. And it partitions it accordingly. If you look at the red and blue here, this is favourable outcome. So the blue is how many people with an MRS of 0 to 2, and the red is those who don't have a 0 to 2. And you end up with these terminal nodes, and this is a group that we've delved further down into the paper with more severe stroke. And these are people with milder stroke. The main things to see here is that we start off at this level with stroke severity, which we know is an important predictor of how people are going to do at 3 months. We get to age, and then down here we start bringing in frequency and amount, and they come into play. So we've put lots of factors in here, and again we see that increased frequency improves outcome, and reduced amount of training improves outcome. So for now we're looking at this in more detail. As I said before, it's a complex picture because it's a lot of data that we have to try and work out how to model it. But the dose response analysis suggests that there's something in there around the frequency versus the amount, and that I'm talking to people about the Goldilocks principle. It's not too much, it's not too little, it's just right. How do we work out what's just right? And who do we do that for? And that's what's important. And we don't know enough about the brain biology in this acute period. That's absolutely given for me. And that work is published in Neurology, which you can take a look at. So in finishing, in 2016, what do we know about early mobilisation now? Well, I've told you a bit about the AVERT trial. I'll talk to you a little bit about clinical opinion, and again around what's also emerged from some of the preclinical work. But this is soon we're updating our Cochrane review. Peter Langhorne is presenting this at the European Stroke Conference. The main thing to take away from this is that here's AVERT, huge data set. This is us here. This is all the other studies. You can see how tiny they are, but there are more of them. So we've got more happening, and in fact we probably have encouraged a number of other groups to do studies in the area, which is great. But of course AVERT's influence, because it's such a big trial, would dominate that data set for some time. Now, what I did prior to AVERT shutting was I was asked by Stroke to do a review of the field, and I titled it Early Adoption but Limited Evidence. And I'm really glad I did, because it's still, early adoption is absolutely there, but there is limited evidence, and in fact the evidence now that we have from our trial is that you have to be cautious. You shouldn't apply this in a one-size-fits-all kind of approach. So what was interesting in that, looking at the clinical practice guidelines, you'll recall that it was mentioned once in 2007, that now it's recommended in 22 clinical practice guidelines around the world, but still poorly defined. So it's in there, but it still doesn't say what we should do. So it just says you should do it, but it doesn't say what. So I have been getting a lot of phone calls, as you can imagine, from people going, we're doing our guidelines, can you explain how we should interpret the AVERT results? What should we put in there? But this I thought you might find interesting. We did a survey, an opinion piece in 2008. We ran it at our stroke conference, where we asked the clinicians at the conference what their views were around early mobilisation for people with ischemic stroke, for people with hemorrhagic stroke, whether they felt it contributed to outcome, and whether they were concerned about it. And we ran it again in 2014. Again, I wanted to do this before we finished the trial, just to see if things had shifted, given that our study had gone on for a long time. And you can see here we got 241 participants in this next one, and this is the breakdown of them in terms of whether they were from the medical profession, nursing, therapy, how long they'd worked with people with stroke, etc., and their work environment. We haven't published this yet. This is new, and it's not yet been submitted. But here are some of the key questions that I've just pulled out for you. And here, is it harmful to start early and intensive out-of-bed activity within 24 hours following ischemic stroke? And you can see here that if you look at the percentage who agree, it's only about 20% who are going, yeah, potentially. And that didn't really change. Is it harmful for hemorrhagic stroke? And this went down. No evidence, no new evidence. Isn't that interesting? I think that's really interesting. Is it helpful then to do it? Well, 80% of people think yes, it is helpful. Let's start within 24 hours and do intensive training. And is it helpful for people with hemorrhagic stroke? A lot more people thought it was helpful. So I think no change in evidence base, but some change in conversation. The clinical conversations that we have around, and maybe the experience. And we did also look at the people who were involved in the trial and not. And there are only a small number of people who are involved in the trial and delivering the intervention. So, you know, a lot of practice can shift. Isn't it funny when we want practice to shift with something that's absolutely evidence-based, it can be such an uphill battle. And sometimes practice will shift when there is no evidence base because it just sounds like a good idea. The other thing that's changed a lot is there's a lot more data, including work from your group, around exercise after stroke and meta-analyses and reviews that have been done. And I'll just touch on some of our work because I've finally got my head around how to do a meta-analysis in animal models, but Heidi Jansen is absolutely a clinician researcher who's got her head right in this space. And with her review, there were 40 papers with over 100 experiments. And we were interested in pre- and post-exercise interventions and wanted to look at infarct volume, neurobehavioural recovery, and also neurogenesis. And with the neurogenesis, what was interesting, there are only 7 experiments with 113 animals, and they were so diverse in how they were put together and their outcomes, even with their outcomes around how they measured neurogenesis, that they couldn't be pooled. So that's interesting that there's still not a lot of work. And this is Heidi here. And she's just plotted this for me, which is the timing of exercise, and this is a better outcome, looking at the treatment effect versus a worse outcome. And this is day 1, and you've still got quite a few studies that are sitting up here looking good, and some that aren't. And again, you know, as we look at the time, this is an important issue for us to try and unpack, I think. But really, they're poorly defined in start times. 43% of studies didn't really describe the dose. That's actually quite poorly done in a lot of our trials. And the schedule is rarely described. So that's the frequency issue. So when in the day and the schedule of how you pack together the intervention. So 17 years after that initial New Scientist, where are we at? Because I'm still really interested in what's coming out from your space. Much better studies are emerging. But we're still having some challenge in divining timing, dose and schedule in those studies. And there's still a high heterogeneity in how people are doing their surgery and creating their lesions. And it looks like exercise improves outcome, and it also looks like there could be an important window where we shouldn't and important windows where we should, but if we could just get clearer about that would be very helpful. And we need some really more carefully designed studies. And I just have to show this because I've always got this question around the man versus mouse, but I can't believe that this exists. Who would ever run on a wheel like that? So the optimal window to start. So what do we know about what happens and when should we be looking at starting? And here we've got this period probably that's still really important, and we just need to work out what it is. So the next steps, and I'm just quickly finishing, we've gone this way, we have to go back this way because we've got to something that makes us go, now what? And of course we work in this cycle, and we've got a number of things that we're planning. We're extending the AVERT study to an AVERT dose study, given our findings around the dose, if we can get it funded. And we're also doing some work in looking at cerebral hemodynamics in that very early time phase as well, to tell us what's happening with the blood flow in the brain. And this is where I am in Melbourne, and I'm just put that up to show you our Flory website and to invite you to come down. And I will thank you all for your attention and thank Dale for his involvement in the roundtable. We'll look forward to getting back to you. Thank you.
Thank you for your presentation. It was very nice. And I just have a question regarding the outcome. So the main outcome was really the Rankin scale, right?
Mm-hmm.
So have you considered maybe looking at different, functional outcomes, but other scales, or was just like we
The rehab scales,
yeah,
do you mean?
yeah, or other scales?
So we do have some other scales. We haven't reported them yet. So we have mood, we have quality of life, we have the Rivermead Motor Index, we have a number of other things that are secondary.
Okay.
So those we haven't got to yet because we're working through our primary list. And the safety stuff is actually next on the list before we get down to the next tranche. The modified Rankin scale is a blunt instrument, but in a trial like this can pick up those kinds of changes that we are seeing, which are important. The other benefit of it, of course, is that you can use it with, make sure that you get full coverage of your patients. Although we did very well in getting coverage for, say, the MOCA, so we've got a cognitive outcome, for example, you'll still get some loss to follow-up, of course, in those, because you can't do the MOCA on some people, etc. So we've got a lot more outcomes, but we haven't presented them yet.
Okay, thank you.
Yeah.
Julie, thank you. This is a difficult area to get into, and we're very grateful that you took that decision so many years ago. The question I have is, I'm sure you've thought about this. What is the role of the emotional uplift that you would give a patient with a stroke whose world has just come apart, and all of a sudden you're saying, yes, we're going to take care of you 4 times a day, and yes, you can get over this. So one way to have perhaps neutralized that is that in the group that's not getting that, should we give them pep talks about the recoverability from their stroke, just to even the score in terms of the emotional lift?
That's a really interesting question. And in fact, Tony, when we did the phase 2, one of the reasons we had a 14-day mood assessment, which we dropped for the big trial, was because I said to myself, is it possible that people will feel uplifted or will they feel depressed? Because you're actually asking them to do activity that they might be failing at from a very early time point rather than them resting. So I felt it could actually go in either direction. And so it was interesting in that data in the phase 2 trial to look at the fact that people seem to have less depression, so be more uplifted. And we didn't continue that into the big study. We hummed and hawed about it, but it was quite difficult to try and put in a 14-day assessment at that point. But I think it would have been very interesting to do. There is, of course, a lot of discussion around whether we should be using attention controls in trials. Also, we even had some discussion at the beginning of the study about whether we should measure the personality of the therapists to see if that might make a difference. So if the therapists who were the ones delivering the intervention were different to the usual care therapists, and whether they were more positive, would that make a difference? Could that be contaminating? I think it is it's an important consideration. However, I think we don't know enough. So we considered that. We considered those issues and went, what we need to really kick off an area of research is we need to find something. We need to find that this hypothesised benefit is there. Now, whether the reasons for it are unknown, but just let's see if we can see if this package works. Well, it actually doesn't. It doesn't make people better. And I'll put a caveat on that by saying it makes some people better. We know that there are going to be responders in our group. But overall, just your usual care attention where people are getting people out of bed early, starting to do their activity early, is actually fine and of lower risk. But I do think when we've got the issue of trying to unpack the intervention once we've shown that there's some biological effect, then I think we have to take all those things into consideration, because we can't assume that the benefit is related to the intervention that we're proposing. A long answer, but I think that gets to some of the challenges that we've got.
One of the questions about the timing, as you know, over 10 years ago, we published a paper in Journal of Neuroscience where we looked at time windows after stroke in animals when we could, introduce something that we called enriched rehabilitation to see, if timing made a difference.
Yep.
And within a certain time window from 5 to several weeks after, it didn't really seem to matter, worked well, but we never ever went sooner than 5 days. And we were afraid to do that for, a lot of reasons. We're worried about, maybe having worse outcomes. So one simple interpretation of your data, which I'm sure you've thought about and you've been asked about probably many times, is it possible that just even this early mobilization was enough to just exacerbate injury, which we don't really know very much about in humans because the imaging really doesn't have the sensitivity to detect that kind of more subtle injury. Do you think that could explain your results?
Yeah, I think there's, and I haven't shown you, but if you read the paper, but what we saw is we didn't see significant difference in death, but we didn't see a significant difference in serious adverse events. But when you broke them down into neurological and immobility related, the patients in our early group, intensive group, had higher rates of stroke progression. There's a biological effect of doing this. Now then the question is, I think what's been interesting is the dialogue that I've been having with neurologists about, okay, so is this, is it only in people who've got a permanent occlusion? So is it the ones who've actually not had any resolution and therefore have the fact that they can't revascularize, they can't get any improvement in their penumbra? Are you creating a problem for them particularly? Is it just the people with severe stroke? It's not just the people with severe stroke. People with severe stroke in the trial are the ones that tend to have the serious adverse events, but the worse outcome in terms of whether you achieve 0 to 2 is still present in people with mild stroke. So it's not just in those with severe stroke, it's in those who have a mild stroke as well. So that's why absolutely we don't really understand enough about the biology. And then the other issue which you may not know about, there's another trial running at the moment which is a big cluster trial called HeadPost. And HeadPost is about keeping people flat for 24 hours. That's certainly the protocol in the States in quite a lot of centres as well. And is that going to make a difference? Is just keeping them stable, is keeping them flat to try and help make sure that the vulnerable penumbra, if there is one, is going to do the best it possibly can? Is that what we need to do? But then what about the ICH patients? So they don't have a penumbra. So there's something else going on for them as well. So I think, we don't really know what that window is, and we've got to balance it up, of course, against the lying in bed and the risks of lying in bed, which we know are also problematic. And I think what we've seen in the change is that we've seen people move to an early activation in every condition, and that's true. You see it in surgery now, you see it in ICU, you see it in pretty much every part of hospital care because it's all geared toward getting people out of hospital quickly. So I think that whole thing is shifted, but we don't know. I'd be reluctant to keep people in bed, but I think we're looking at a small titration up to when we think we need to then start really going for it.
The other thing that I wondered about is I've talked to a couple of clinicians, about your trial, and they've said, Janice Eng for one at UBC, and she said, well, we're already doing early mobilization. And so then I thought, well, I wonder if you're actually making things worse unwittingly and not knowing. So I think there's a lot for people to start considering, about what's happening in that early time and understanding
happening with the biology.
Yeah,
so.
I agree. Yeah. And as I said earlier, right at the beginning, early mobilisation versus early mobilisation could be completely different packages of intervention. And in a way, we've shot ourselves in the foot by having this global term, because people are, and if I could have $1 for every time someone said, we're already doing that, going, okay, are you? And then I've gone in and mapped in their units and gone, no, you're not. Like, you're not doing that. So I think we have to just make sure we define what we're doing. Look, I just wanted to skip, and I don't know if I can, but I wanted to just say as well in our CRE that we've got a theme that's all about basic science and neurobiology, which I'll talk to you about later. But I just wanted to acknowledge my fantastic group, and I ran out of time, and I have a really fantastic, great group, and the people involved in the trial and my funders. And if you want to contact me, there you go.